Good morning, everybody, or good afternoon. Dr. Gupta is here with me today as well. We'll go through some data points and then take some questions. I know that there's a lot of questions related to the new variant, and Dr. Gupta will talk about what we know and what we don't know about the new variant. Overall, again, with COVID, this is all about balance, and there's peaks and valleys. Today's a good day. Tomorrow will likely be a tougher day. That's just the way these things work. No deaths over the last 24 hours, so that's very happy to report that. When we look at hospitalizations, we have 136 residents in the hospital. 32 are in the ICU. Out of the 32 in the ICU, 78% of those are unvaccinated. Again, the vaccine is the tool to keep yourself out of the ICU, and the booster shot as well. Everyone essentially qualifies for it, 18 and above. Everybody should go get the booster and get it scheduled. I'm going to get mine sometime this week. This morning I spoke to the leadership at all three hospitals to discuss capacity and current status to understand their operational challenges, and the feedback was good. All three hospitals are holding their own related to COVID. We're going to continue to monitor this, and we're going to work on various metrics, but the situation is so fluid, it's hard just to put a number out there right now and to say if you hit this number, it triggers X or Y. Last year at the peak of this, we had over 300 county residents in the hospital and over 400 residents regionally, essentially in our three hospitals. That's not the capacity where we are this year, basically based off of numerous challenges, fatigue being one of them, competition for traveling nurses being another, and then to a lesser extent some of the vaccine mandates. All three hospitals talked about the fact that their emergency rooms do get crowded at times, and then you have what's called diversions, where they will diverge clients or patients to other areas as they're coming in. And a lot of this really is avoidable in certain cases. They ask that we remind folks that the emergency room is for a true emergency. You should not be going there for a COVID test to get that. You can get that via our testing infrastructure. You can get that in an urgent care. Also, we really need all of our medical infrastructure to start really working together better. And we're going to do that and help facilitate that. But certainly, we need support from every level, primary care doctors, urgent care doctors, and facilities to treat patients and not essentially default to emergency room stays. What we know is that there is capacity today. COVID is not the number one problem in these hospitals. They are seeing other types of illnesses that are creating pressure. The pediatric hospital is seeing other types of challenges and respiratory illnesses that is creating challenges, but it's really a staffing issue right now. So we're going to continue to work with our hospitals, consult with our health department, and try to come up with metrics that would help trigger potential mitigation if it hits that. We think if we stick to the basics, we won't even get there. But all three hospitals spoke to them today. They are all in good shape. Some of them have specific requests for us to go help advocate and lobby that will help them be in better shape. But overall, good calls. Active cases are down to 1,147. There are new cases today, 121. Another low day. Looks like tomorrow is going to be a high day. So we take these things in balance. Last week when we spoke, we were at 52 cases per 100,000. This week, today, we're at 39 cases per 100,000. So we saw a 25% decline in cases. That's probably the Halloween surge essentially worked its way through, getting back to a baseline. We'll know later this week and then next week what Thanksgiving likely will do as far as cases go. So we'll have to see about that. Out of the 121 cases, 33% of them were household contacts. and 18% of them were between 0 and 11 years old. Related to booster clinics, we have next Tuesday at the Civic Center from 9 to 4. Please go to ongov.net to register. Also on our health department page, if you go there, there's various options for a booster or for a vaccine at other facilities as well that you can look to try to register as well. Related to vaccinations for school-aged children, to date, we have now in the Onondaga County vaccinated 8,078 5 to 11-year-olds that have received their first dose. In 2 weeks, this number increased 2,900 children, so 8,100 is over the 20% threshold. So we're making progress there. We want to thank our pediatrician offices, our own health department, all of our partners and the pharmacies as well, who have helped us go through this process. School-based clinics this week are related to second doses, which is obviously critical for this demographic to start to build up that immunity. And then on December 7th, there will be a school-based clinic at the Montessori School, and on the 16th, there will be a school-based clinic at Solvay. Related to school-based testing, in the month of November, we did 10,663 tests. We identified 80 positive cases, 0.75% positivity rate related to inside the school with our testing program. So clearly schools in the percent of positivity are a lot safer, and the spread is still not something that we see happening attributed to schools. Certainly, when you look at a lot of those household contacts each day that we report, a lot of them are children getting them from parents, often vaccinated parents at this point as well. Our administration in the beginning of the year at the state of the county basically outlined our priorities, and one of our main priorities was keeping kids in school. We need them in school to deal with all the related pandemic challenges. Part of today's call with the hospitals, we spoke about kids. We talked about what challenges they're seeing. A lot of the challenges they're seeing at our pediatric units are related to mental health. That's why we've supported with mental health clinics in all of our school districts. And we know we need to keep kids in school. There are various tools to do that are challenging. And as we continue to adapt to the ongoing playing field that COVID has brought us, we need to continue to increase our daily living activities because there's a new variant coming up and there will likely be another one after that. So part of that is learning how do we keep our kids in school. And school districts do have a test to stay option related with quarantines. And that is something that we will do anything we can to partner with schools to have that be an option so that kids can test daily to stay in school out of a quarantine if they were a contact. And that's something that the school district determines that, but that's a policy that we want to encourage and support, and certainly with best practices. A reminder based off of kind of where we are moving into kind of uncharted territory this year. It's tough to compare 12 months ago. I know it's easy to do that from a data standpoint, but everything was so different 12 months ago. We had, I believe I was reading Glenn Coyne's article, and he shared how last week we had fewer cases than the year before, and how things exploded shortly thereafter that, right? And we were doing things last year related to certain mitigation that we're not doing this year. So how come less this year than not last year? And then, well, we have a vaccine tool that's better, and that's helped us really ward off to some degree, this extremely transmissible variant, the Delta variant. So things are so different. But what we do know works is as following. We need to continue to vaccinate the public. and people just look at that ICU number and look at how many, we have about 84% of our community over 18 has received at least one shot. About 73% of the community now overall has received one shot. And so 16% of those over 18 are driving 78 to really 85% of our ICU stays. And those are the folks, unfortunately, in many cases, the majority of cases, when we report deaths, that's where they're coming from. So please talk to your medical professionals, your doctor. Please consider getting the vaccine if you have not. Second, we need to get our booster shots. Please, please, please get your booster shots, get it scheduled. There's all sorts of data out there. There's lots of studies. And it was always the understanding that the vaccine will be strong for so long, and then at some point the immunity will wane. And certainly the booster shot's a tool to help you. Third, this is like really the one thing that I think if we can just be smart about this is common sense, we can all do it. We'll continue to have success, is stay at home when you're sick and get a test. If you're sick with any symptoms, we all know what they are now, stay at home. You have to rule out COVID. That will help prevent you from passing it on to your family, passing it on to your coworkers. And certainly that's the easiest way to avoid transmission. If you're sick, stay home, get a test, rule out COVID. Fourth, certainly our guidance has been masking indoors in these winter months, specifically when you're in large groups of people and you can't physically distance. And then the fifth thing I want to touch on, which will help our hospital capacity as well, is certainly when you're sick, and many people will continue to get sick. This is a very contagious variant with the Delta variant right now. If you get sick, talk to your doctor about treatment and therapeutics. The monoclonal antibodies are one that many people have gotten right when they get sick if you're in certain demographics, and that's helped prevent hospitalizations. So please, those are 5 things that we're going to continue to message, and if we can do these things well, we'll be in a position where we continue to grind this out through the winter months. At this time, I would like to have Dr. Gupta come up and talk about where we are specifically about the new variant, the Omicron variant, and certainly after that we can take questions. Dr. Gupta?
Sorry, good afternoon. Can you hear me? Okay. So as you all have heard about Omicron, a new variant which has been discussed in every news outlet, CDC has put a statement, first WHO put and then CDC put it, started in South Africa. It's spread through all provinces because it's highly transmissible. That's what seems to be the fact. Since then, it has been detected in Australia, Belgium, Botswana, Britain, Czech Republic, Denmark, Germany, Israel, Italy, and now Canada too. So as of it now, I did not check the latest news right now, but as of it, at least when I saw last, was not identified in the United States, but it won't be surprising if it will be, that somebody will come out and say, yes, it was there. What we know about this variant is this is variant of a concern by the WHO definition. It means there's enough concern that we are going to look whether the vaccine, whether the treatment, whether testing all will be really continue to work the way it has been through other one. If you remember in April when Delta variant was the one became very prominent discussion throughout the world was happening in India. And since then, it has pretty much gone through the whole world. We were having the same discussion. What will happen? It's highly transmittable, whether the vaccines will be effective or no. Fortunately, vaccines have been effective for that, and that is the one which we are going to stick to the point at this point, that this is a new variant, and the part of the problem is that until we have lower rates of vaccination, when I say lower, it's relatively lower. We have high rates, relatively higher in our community. Over 65% have received 2 doses of vaccine, but the variants arise throughout the world. So in Africa, you have a little bit over 30% of vaccination. So you have many people who are not vaccinated yet, and providing those human bodies to virus to replicate. When it replicates, it creates billions of copies in our body. And those few of those copies are defective, and some of those defective can die out on their own, and some of those defective become more virulent, more stronger, and that's where we identify that they are pretty much become predominant. So at this point, Delta has taken over most of the United States. The question is, with Omicron, will pretty much supersede that in the few months? We don't know that question. The other question will be whether the testing, which is available at this point, especially PCR, is going to continue to be useful. Seems like it will be, but we will know more in a couple of weeks. Will the vaccine be effective? That is something, when we look into what we call neutralizing antibody, it means those people who have recovered or who has gotten vaccine, whether before, those things, both Moderna and Johnson & Johnson, as well as Pfizer, they're all working to see whether they can see neutralizing antibody enough sufficient level there that it can actually counteract against this virus. So a lot of those things are unknown at this point. There are some initial findings have been that it's highly transmissible, but it may be causing mild illness, but again, it's very early in the stage at this point. So what I would remind everybody, what we have in front of us, we have Delta in our community, and we have plenty of vaccine in our community. There are a little bit over 30% of people who have not gotten vaccine. I would say they should pick up the phone and call and get the appointment for the vaccine. And make sure that whether it's a child, 5 and above, 5 years and above, or anybody who should be getting booster dose, everybody needs to be really on board. Masks still work. Vaccine does not mean that we leave everything which we learned past year, which was so successful without the vaccine to control the rates in our community, that we should leave them behind. It means we should still do those common sense public health measures, using the mask, especially indoors, if you don't know many people. Really, you need to be not uncomfortable about putting the mask on. When I go to grocery store, when I go to some place where I don't know, I'm going to always put the mask. And I would encourage you to all to do that. And keeping the physical distancing, if possible, that will be very important also. And if you can avoid unnecessary, crowded situation, at least for next 2 weeks, we really need to learn more about this virus. But it's a reason for concern, but not reason for panic. I think it's very important to remember. We don't need to lose our sleep over it. We have gone through a lot of those things and has come quite well. So I would like everybody to be just making sure what is in your hand. Make sure you get tested. If you have symptoms, stay home. If you have any symptoms, get vaccinated and use your mask. These are the things, if we do, I think we can create a significant barrier that we hopefully will be able to curtail and kick this virus out, keep that out from our community. And if it does come, I'm hoping that vaccine will be effective. So there'll be more to come in the near future. Thank you.
Okay, questions?
Does the governor's state of emergency have any impact here? Will that change anything you're doing or the hospitals are doing?
So the hospitals have to manage their ebbs and flows now related to elective surgeries based off of some metrics that the state has put on them. So upstate, for example, hasn't been doing elective surgeries for months. Crouse is still doing some, still has the capacity to do some. St. Joe's is still doing them. So I think that's how it impacts the hospitals. We asked the hospitals basically, help us understand, let's go backwards from our peak last year, 400 people in the hospital related to COVID. Help us go backward based off what's happening so we can identify metrics where we're really in trouble. And the reality is the actual bed space in the hospitals is there, and they could have actually done more last year. It becomes an issue of people. And so there's certain things that, Upstate's a state-run hospital. They have various rules. They're not as flexible as a privately run hospital. If they could pay people more, they would have more people there, which creates more capacity for the region. But the governor's state of emergency impacts them related to elective surgeries. For us, everything we do is data-driven, and we're looking at the data, and we had a good week overall. We may have a tougher week next week. We don't know yet. And certainly if there's a sustained period where it looks like transmission rates are very, very high, and that it's going to eventually impact hospitals based off our past experience with the virus, then we have to look at potential mitigation. But right now, it was a good week. We don't know a lot about the variant. We'll let the doctors talk about the variant and what that could or doesn't mean. And eventually it will come here, and maybe we're talking about the Omicron variant for 6 months before we're talking about another one. But certainly we need to be able to treat our sick in the community, not just COVID-related patients, and that's the broad discussion with hospitals. Some of our other medical partners, we need them to kind of shift and take some of the load off the hospitals. As if you think about it, certain doctors' offices, if someone has COVID symptoms, they may not want to see that patient because that patient could potentially bring COVID into that office, which then could knock out potentially those employees, and then they're not there to treat for weeks. We need to figure out a better way than just to send them to the hospital, those patients, and we'll continue to try to facilitate those conversations.
What's the total number of hospitalizations?
136.
Did the hospitals give you a number that you were looking for, a metric, a number of hospitalizations that would constitute an emergency?
They gave me right now, without having to do various things, how many more patients they could take without having a problem, we're going to kind of sit down and think that through. Certainly, there's the number's higher than 136. Okay.
How much higher?
It's higher, but we don't want to put ourselves. I'm not going to box myself into a number yet, Andrew, because you want to give yourself a little bit of time with that number in the event that you think you can do some mitigation, that you give yourself time to let it have an impact and not get yourself to the boiling point. The big issue with hospitals is staffing, and we need to figure out a way. There's traveling nurses, right? And these traveling nurses continue to go from hotspot to hotspot in the country. Florida used to be hot. Now Florida's not. People are outdoors again in Florida. And so where are all those traveling nurses going? That's what at the state level, they should really be focused in on, is getting that medical infrastructure in these communities, specifically in upstate New York, where the staffing issue is being hit harder than it is in downstate.
Well, so you're not ready to set a metric that would trigger masks and other things, but what number did they give you that would be concerning to them? At what number of people in the hospital, number of patients, would they start to be alarmed?
They don't. That's not how they operate. They operate basically every 3 days. So we're going to put some thought into it. I know what the capacity is in all of them right now. I challenged them on that point. So
what is it?
I'm not going to box myself into a number today.
You box them into the number. Can you share it?
Not yet, because we just had these discussions before this. So I'm going to sit down and talk to my health department too before we put out ideas. With cases, it's different, right? We look at what other communities did when they got to that point and started to look at mitigation. But from the hospital number, and that's really what this all boils down to, we're not going to box ourselves in yet. And that there's room for that to change. We told them we could put out a number and they could call us and say, because of factor X, Y, and Z, that number doesn't work for us anymore and we need your help. Understanding that the tools the government has are not the best tools. The best tools are what we already talked about. We can't, and when you're in my role, you have to look at every pandemic-related challenge at this point. We're essentially almost 2 years into this. And everything at different points of this, we had to, I won't say overreact, but overemphasize certain points of this pandemic, which was appropriate at the time, but there was unintended consequences. And so we need to balance all those out when we're looking at policy, and so that if we do have to act, and I do have to make tough decisions that will make people upset for a period of time, that they take that decision seriously, and they know that this is not a knee-jerk reaction, that this is thoughtful. This is something that we just didn't jump to when others suggested we should have, and so that people comply. And then because if you can say whatever you want in this podium, if nobody complies, it's useless. Because we all know some of these tools we have are very difficult to enforce, if not impossible.
How will we know if
Was that?
How will we know if Omicron is here? Who does sequencing? How much of it is upstate, Wadsworth?
So the sequencing certainly is going to be done by the Wadsworth, and probably, I don't know about upstate, but they are looking into having many labs who can do the sequencing. So we will know when it is here, because I would think the first will be the state Wadsworth lab, will be the one who is going to confirm, first from the CDC and then from the Wadsworth. Commercial labs, normally a lot of them don't do it in the beginning. Later on, they can actually. I know with the upstate, we were able to do with the quadrant, the Delta variant. You can actually get the sequencing from them, so we could find out. But how far that will be in the Omicron, that is something I'm hoping that will happen.
What percentage of tests get sequenced?
Depending on in the past, they used to do a very small percentage. They will take a fraction and sampling. At this point, I have no idea how many that will be, but they will start with some sampling throughout all the counties. They take it when Delta came in the beginning. They took a small sample because we were kind of asking them that what is the situation in our county, and they had like a small sample. But then since then, I think the commercial labs have increased their capacity, so hopefully that will be helpful in the near future.
Dr. Gupta, you've worked in a hospital before. What are you hearing from inside the hallways where it sounds like there's not enough people, not enough working people, too many patients? What's the general mood like in the hospitals, many of which you've worked in?
So I don't work at the hospital now, but I certainly have been very intimately worked at the hospital as a hospital doctor and took care of patients there. The people, the colleagues which I talked to them, staffing is a concern, as this is not hidden from anybody. And people are exhausted. The healthcare workers are very, very, very fatigued for the long hours, short staffing. The same people have to continue to rotate. And they really need to, the biggest concern is at this point that can we take care of those people who are having heart attack, who are having COPD exacerbation, who need urgent surgeries. All those things are important. And they continue to do. I think kudos to all the hospitals throughout the country and throughout the world, actually, that they have stepped up and able to do what they can do, considering the limited capacity everywhere, actually. So I think we just have to go through it. And one thing which I would like to remind everybody is that when we talk about prevention messages in terms of testing, tracing, and vaccination, that all will help in the front end, that will help improve the capacity of the hospital. If we can take all the burden away by having more people vaccinated, by keeping those people, providing testing capacity to the providers, having the testing in their offices, and making sure that home testing is available also to people, and continue to have those people who are sick. Not everybody needs to go to the hospital. So if that's the confirmation, then certainly we can avoid those overcrowding of those EDs, which I personally have talked to many ED directors throughout the pandemic and a few months ago also, when the pediatric testing was not that available and all pediatric kids were going there. So we came out with the outpatient clinic, which was done to the testing. The same way, making sure that all the family physicians or doctors' offices have the testing available to them, whether it's a nasal swab or the saliva, depending on, and do we have that enough, depending on how many providers want to participate. The same conversation I have had with the New York State Department of Health, with their leadership, when we have our conversations from local health department perspective to increase the capacity in the provider community, so they don't have to push them and say, hey, go to emergency room. They can say, come on in, we will do the test, and you have mild symptoms. Do we need to refer you for the monoclonal antibody? They can connect to them and then take care of them, a lot of those things, without sending them to emergency room. So a lot of those connectivity happen in the background and continue to have their dialogue. There are many moving pieces in this, what you see it at the outset.
I'm not sure which of you would like to answer this question, but the county executive mentioned that COVID is not the dominant problem of the patients in the hospital. Does that mean COVID is not dominant compared to all non-COVID, or does that mean there's something else that has more people in the hospital?
I mean, I can give some answer to that. Look at the bed capacity of each hospital, right? And you look how many COVID patients are there. So you think of the flow in the emergency room, how many people, they have people coming from overdose, they have people coming from injury, they have people coming from gunshot wounds or some other mental health crisis and all those things. And then how many in inpatient beds, they have medical floors, and they create usually what we call a COVID floor if we need to, right? So when the cases went down, the COVID floor sort of disappeared, and they were utilizing some separate area to use them, and when the cases go up, then they designate the whole floor as COVID floor. And rest of the beds are used by everything else, because the human disease always happens, right? Heart attacks happen, the acute appendicitis happen, gallbladder happens. So all those things, so depending on if there's a 500 beds or 300 beds, depending on what the capacity is, how many you have the COVID patients right now, you can think of that. And some people, they keep on testing, so some people, the question is, what you are asking, that are they overwhelmed? So there are more disease in the community than the COVID itself. So look for the capacity, and then look for that will give you partial answer, actually.
At 12:30, Ryan, this is probably for you. The Department of Health sent us a list of 37 hospitals across New York that had 10% capacity or less. Upstate and Crouse are on there, meaning under the state of emergency, they will have to limit elective procedures by Friday. Were you aware of this capacity issue? Are you prepared for, it sounds like Crouse would be the one who would have to really limit elective surgeries.
Yeah, well, Upstate hasn't done elective surgeries for months. Dr. Cronenberg talked about that today, how he didn't know essentially if they'd be there, but they also, they don't necessarily, not all the hospitals agree with the metrics that are coming out by the state as a true reflection of their ability to do their job and treat their sick. So I'm sure Crouse will probably be disappointed if they don't win that argument with the state related to the ability to continue to do elective surgeries. Because the electives, a lot of these surgeries, and Dr. Gupta can talk about this, but these aren't vanity surgeries. These are people who are sick, and this is probably the most important thing in their lives with their own personal health, right? And so certainly little surprised to see the state pull that trigger right now. Obviously, most of these hospitals know their capacity overall. They manage it really, like we talked about with Andrew, in 3-day increments. And so I thought it was a surprising move for some of the hospitals based off of some of the metrics.
Would you clarify what I asked a moment ago about, did you say the non-COVID, is it in total?
Yeah, you look at total non-COVID, right? So COVID is not driving all the beds in these facilities. None of these 3 hospitals have more than 50 patients essentially right now, maybe a little bit over that. Some of them have 30, some of them have 20, based off of the math, how it works on a given day. And again, today you're talking about a holiday, still getting over essentially a holiday long week. So you're discharging isn't up to where it normally is either. And one of the things we did also talk about, though, is the transition from folks back into long-term care facilities is not where it needs to be, and that's something that we're going to talk to the state about, because that will open up so many beds as well.
Yeah, I was going to ask, what did the hospital administrators tell you about? You said that they want you to advocate on their behalf. What are some of the areas? What do they need from other levels of government in which you can advocate?
Yeah, I think upstate needs to be able to pay people more. They're under kind of government type regulations, which I can appreciate. You have to negotiate these things, and they feel if they could pay people more, they'd have more staff, and they certainly have the most capacity from a physical blueprint to do more. Certainly, there's other ways that the whole system can interact with each other and do better to continue to make things be a little bit more efficient on the time of people getting in, getting out, the right people going to the right places. And there's some things we can do with messaging with that related to mental health with young people, so we'll certainly do that. But overall, we're what, in December right now? This is right when we started to see things really get interesting a year ago. We have better tools now with the vaccine, with the antibodies, and certainly I think that if we can do what we need to do, this isn't going to be a winter like it was last year, because that your overall public health will be greatly deteriorated if it is. We can't have upstate not doing elective surgeries for 5, 6, 7 months at a time. Those are all people that are just waiting and waiting and waiting, and that number of people that need those medical procedures gets backed up way too much.
Ryan, between the 3 major hospitals from that state data, it says they have about 50 beds available between the 3 of them. When you talk to them today, does that number sound about right?
No, not at all.
So is the data wrong from the state then?
Yeah, I don't know the metrics the state's using. I don't understand how it is and how it would apply. When I see metrics applied to us that I think are wrong, I talk to you about that all the time and say why I think there's a bias there. But I know that number's not correct, because they told me the numbers that they have available just for COVID patients, and it's higher than that.
Well, do you believe there might be a disconnect when we talk to hospitals and they say they're in crisis mode, and then you talk to them today and you said that they're in good shape?
They're in good shape related to be able to treat more people. Crisis mode, I think, is the point that Dr. Gupta and I alluded to earlier. When you're in month 21 of a pandemic, the frontline workers have been asked to do more than they ever have before for longer than they ever had. A lot of ways that you deal with that fatigue is you pay them more. Some of the hospitals can't do that because they're under certain restrictions. And there's staffing pressure that's there today that wasn't there. But when you look at the activity from a year ago, the activity was higher, meaning there's more sick people. So everybody in the healthcare world, you could make a strong argument, is in severe constraints or crisis mode. That doesn't mean that they don't have capacity to treat more people who are sick.
So 50 is wrong?
There's more than 50 beds in the community available.
How many?
I'm just talking about COVID. There's more than 50, and let alone there's other beds. Again, a lot of this is the way that the system works. If we do things as a community, you don't go to the emergency room unless it's an emergency. You reach out to your urgent care, primary care, or some of our testing sites to get a test. Basic things like this free up space so that the hospitals can treat more people quicker and get people discharged quicker, which opens up capacity.
Within the hour before your briefing, the Monroe County Executive declared a state of emergency specifically regarding the number of people in the hospital. What's your read on that, and how does Onondaga compare to Monroe?
Yeah, I haven't talked to Adam Bello yet. We spoke last week. But their cases per 100,000 were dropping as well, but that would lead to hospitalizations starting to drop really 2 weeks from then. So they were in the high 60s, they're in the 50s now. And so again, if he had the same call that I had and his hospitals were saying they have a real problem, then he made the right call. What would it take for you to do the same thing in Onondaga County? We'd be at a tipping point with capacity 3 weeks before a tipping point, which we're not.
So we're not within 3 weeks of a tipping point.
No.
Going forward, are you going to be checking with them on a regular basis too?
Yep.
I mean, is it weekly that you talk to them, or?
Yeah, I think the health department interacts with them every day. My deputy county executive, Ann Rooney, interacts with them every day, essentially, with at least one of the main hospitals. So they all heard from me directly today that if anything changes on the ground, let me know what that is, and then we'll start to look at mitigation. Understanding mitigation is not the silver bullet here. Putting vax or test requirements on large gatherings could be helpful to identify COVID from getting into a large gathering and spreading, but that will take time to see impacts. We know the tools that will help us right away. And go get your shot, go get your booster, and if you're sick, stay home.
Let's just go back. So Onondaga County is at least 3 weeks away from a tipping point. Why is that 3 week range important?
You're looking at it the wrong way. You need any mitigation that you do today will not have an impact for 2 to 3 weeks. So that's the way it is. If they told me today, what we want to look at is the capacity that's there. When we get to this point, we know we're going to have a problem. We want to then give ourselves a 2 to 3 week cushion in that number. So that number would be smaller than the capacity number.
And you've deemed it not at that point.
I didn't deem it that. The three CEOs of the hospitals deemed it that way.
Brian, twice you've mentioned youth and mental health by, getting into mucking up the system somehow. What's the problem there? Is it the lack of mental health services? Are there any particular issues that you're dealing with?
Yeah.
Suicides and drugs?
Yeah, there's all of the above. So you have our pediatric hospitals seeing a severe increase in mental health cases, as that's what it's there for, to treat those people. That's a pandemic-related situation. Talk about 20 months worth of isolation and change. That's directly correlated to the pandemic. So when we look at things broadly, we don't just look at a virus and people being sick at the moment in time. We have to look at all the various impacts. And so you're seeing upstate is seeing a lot more mental health pediatric cases, which makes sense. And certainly working with ways to encourage the younger kids to go to the upstate, and then some of the older kids to potentially go to St. Joe's and CPOP. These are things that we'll work through with our mental health services that we have in the schools. But you're looking at, those are the types of pressures that the hospitals are seeing now that traditionally they would see some, but not at this level because of the pandemic.
I'm going to word this gently. It seems that the state isn't taking any quick action in terms of policy changes. It doesn't seem like the county is taking any quick action in terms of policy changes. How do you break this continual rut of cases, especially as you head for a potential winter, December, January surge?
So the cases, I would disagree, first off. I don't know if there's much. I think there's a sense that government is the reason we did well in this. It was never the government, it was people. Because we can say whatever we want. If people don't respond, then you're not going to do as well based off of the science and the data. So if there was a silver bullet that said if we do X, COVID's over for the winter, I don't care what it is, we would do it. I don't care what would happen. I wouldn't care if I lost my job because people are that upset. But there isn't. Okay, there's tools, and we have the tools that we know are the most effective. So what else do you want government to do? We've heard I hear it every day on the left side of the political spectrum and the right side of the political spectrum. And one is saying, because you don't lock the community down again, you're responsible for the death of the community. And the other side's saying, don't you dare do this or else there will be revolt. Okay? But it's when you have that, you need to build up consensus through data and through science that there's a problem. and then you can make good decisions, and people might respond. What we have now, Andrew, if you look at this where we were from a week ago, we're in a better spot, 25% better spot, 25%. So that doesn't mean we'll be there next week, but that's where we are. Cases are 25% less this week than where they were last week. That doesn't mean next week they won't be up 30% again. But what we do know works is go get your shot, go get your booster, and stay home and test. And if you do that, and if you get sick, call your doctor, go get the monoclonal antibodies if you are there. And if you have pre-existing conditions, it's probably a good idea to really start to listen to some of the advice Dr. Gupta was giving about what are your social activities and what are physically distancing and things of this nature. These are things that you don't need me to mandate. This is common sense at this point.
It seems odd that the state's capacity numbers are just outright wrong. How do you suppose these numbers differ from what data you have?
I don't even understand how they got the data, so I'm not going to suggest it. I can tell you I was on the phone with the teams that run the 3 hospitals today, the top executives, and let alone they told me they had more capacity than the 50 beds that someone referenced just for COVID beds. You would assume you would have more capacity for everything else that they do. It's all about people, and it's all about timing when they bring people in, I believe. So they staff up to the challenge in front of them. And so if you have more people coming in to the ER, you're going to staff up with people for that. So I don't know what metrics they're using, how they're using the cutoff timing or whatnot. So I'm not going to get into that. I can just tell you for a fact, they told me within the last hour and a half, they have more than 50 beds in the community. That's a fact.
Well, it seems like testing is the issue. What are the people that are getting sent to the emergency rooms? The doctors are?
Yeah, we heard that today from the hospitals, that there's some primary care physicians that do an excellent job. Sometimes they'll be concerned that they don't want necessarily to deal with COVID patients or potentially COVID patients, so they get pushed to the hospitals. Well, Dr. Gupta's already been working with the Ontario County Medical Society on this issue, and we'll continue to message that.
What was their mood like?
They're all professionals, and they all know that they're in a unique moment in time in their careers, just like we all are, and that their community needs them and needs them to be at their best. And so they get that, and I think they're all very practical people, and they know it's a fluid situation, and that's why they plan for every 2 to 3 days.
It was Dr. Corona?
He was one of them.
Who represented Krause?
Dr. Cronenberg.
And who represented St. Joe's?
A team of folks, Dr. Falcone, Joe Bick. So they're a team at St. Joe's. So good conversations. We got a lot of good feedback. We have some different ideas that we think we can be helpful with, and we'll try to be helpful with that.
It was a group of your leadership, county people, and the 3 hospitals exclusively?
Mm-hmm. Individually.
Individually, 3 separate
Correct.
Zoom meetings?
No, phone calls.